Hi, welcome. I imagine you're here today because you're planning on having a total joint replacement here at Jefferson Hospital, either a hip or a knee. And my name's Ann. I'm the physical therapist that has the distinct pleasure of meeting you and working with you and going through this process with you. So my area of expertise actually is working with orthopedic joint replacements. This is my 34th year as a physical therapist and my 4th year here at Jefferson Hospital. So today, we're going to work on what you need to do to prepare for your surgery. Okay? So this is a process I want to remind you is it's a little lengthy and tedious perhaps, but also one well worth your efforts. Okay? So I'm with you on this journey. If you have questions, we're going to show you my email along the way and towards the end, and you can always contact me. And I want you to remember that when you come into the hospital for a joint replacement, you're not going to be sick. Okay, you're getting a replacement part, and it's something that we've done a lot of times. It's a big team of us that does this, okay? So today we're going to hope to reduce your anxiety, but also help you be prepared for your surgery and familiarize you with the units, okay? So this means we want you to be strong and prepared for surgery, not just physically, but mentally, so that you come into this without any questions that are unanswered, and that when you leave the hospital, you're totally confident that you had exactly the experience you were looking for. Okay, so at the center of this, of course, is you. You're the one coming in to have the replacement, but it takes a large team of people to actually do a joint replacement. There's your orthopedic surgeon, and here at Jefferson we have 3 very good and gifted orthopedic surgeons who I wouldn't hesitate myself to have surgery with. They're great, great people. You'll also see a physician's assistant. You may have already. And these are the people that are helping in surgery, but also come around in the hospital and oftentimes are the ones writing orders for things like medications and your discharge. So important folks. Then you have your rehab team. Okay, that's myself as physical therapist. We also have occupational therapists that work with you. Now, oftentimes people will ask me, well, what's the difference between a physical therapist and an occupational therapist, okay? Physical therapy, I'm interested in your mobility, your abilities to get in and out of bed, up and down from a chair, walk, do stairs, anything like that that you have at home. Occupational therapy works on your ability to get dressed and get in and out of the bathroom, the shower, fix a meal, those kind of things. So we all work together on your safety and making sure that you have the most successful discharge that you can, but we do a little bit different things, okay? Nursing staff, of course, these are the folks that bring you your medications and things, so make sure you stay on their good side when you're in the hospital. Your certified nursing assistants are the ones who answer your call light, bring you water, food, help you to the bathroom, those kind of things. Please never hesitate to use your call light, okay? Sometimes people will get up and not realize that they have something attached to them and trip or something. We don't want to see that happen. So please, until we tell you that you're free to move about on your own, you need to use your call light, even in the middle of the night. Don't worry, people aren't sleeping. They're there for you, okay? Then you have your anesthesiologist. You'll probably see them pre-op in a meet and greet before your surgery, and then they'll be present, of course, but you'll be sleeping. You may see them briefly after your surgery as they're part of our our pain management team, but you won't see a lot of them. So most of our joint replacements have a combination of a spinal anesthetic now and a conscious sedation like Versed, okay? Personally, I don't know what's conscious about it. They gave it to me and I was instantly asleep, but in theory, it's a lot lower level, and the spinal allows them to numb you from the waist down so that you actually come out of this anesthetic much faster than you would with a general. A few people will have a general, but that's up to you and your surgeon when you speak about that, okay? So the beauty of it is there's a lot fewer complications than if you had a general. A lot less nausea, vomiting, headaches, those kind of things. Then, of course, your primary care provider is your umbrella over this, overseeing it. Not going to come and see you at the hospital, most likely. In the hospital, we have doctors called hospitalists who would act as your general doctor while you're here in the event you needed one. So they manage those kind of things for you. Now, we're going to talk about anatomy. First, I'm going to talk about the knee, show you the knee. If you're having a hip done, you can either fast forward through this or you might find this of interest. But let's look at the knee joint, okay? I've got a nice schematic of it here, but I'm actually going to show you a little model here as well, okay? The knee is a nice, fairly straightforward hinge joint, okay? It is actually the largest joint in the body, has more nerve endings than any other joint in the body, so you can draw from that that yes, you're going to have some pain, okay? As you're going to have some remodeling to the outer layers of bone, and that's where the nerve endings reside, there will be some pain. And we'll talk about that again later. But the three major players bone-wise in the knee joint are the femur. You're looking at the top of the femur right here, coming in to sit on the bottom of the femur sitting on the top of the tibia. So if my right hand is my tibial plateau and my left hand is the top or the bottom of my femur, it just slides and glides like this, okay? Just like this model right here. The third bone in the knee is the patella, or the kneecap. If any of you hear popping and clicking, what I like to call Rice Krispies in your knee, that's usually coming from roughness on the back of the kneecap. There is a fourth bone here, the fibula, that you can feel that bony prominence on the outside of your knee. Not a player in the knee replacement, but it is there as a strut. Okay. Now, these bony surfaces have gotten worn out over time. I'm sure that each of you has heard by now that you're bone on bone, meaning that these nice, lush shock absorbers called menisci in the middle of this joint have gotten thin, okay? So that's one type of cartilage, the meniscus. As that's thinned out, then those bones become closer to each other and become what we call bone on bone, okay? Now, you can't see it in this presentation, but if you get a chance to look at a joint model when you come in and visit with our orthopedist, you'll see that that these surfaces of the bones are also very smooth and shiny, okay? That's your articular cartilage, so the second type of cartilage that I was talking about. And what happens, unfortunately, as time goes by, is that those surfaces can have erosions in them. So if you look at this, and I open this joint up a little bit, you'll see some orange there, perhaps pink or orange. Those are actually erosions in that cartilage, because as those surfaces that aren't meant to be close to each other become close to each other, they show that wear, okay? So this joint model right here gives us a really good idea of where you probably are right now. If you could see this and feel this, you'd see that basically the Grand Canyon is in there right now, and that's not where you want to be. You want to get back to some good health, okay? So also, in the joint itself, you have tendons that hold the joint together. The tendon actually attaches muscles to bones, okay? You have ligaments that are bone to bone. Those things are not disrupted. They're simply moved aside. So for a knee replacement, they're going to make an incision right over the top of your kneecap. It's not super long, a lot shorter than they were 20 years ago, okay? So you'll still be bathing suit worthy. And incidentally, people ask me, well, how many staples or stitches am I going to have? They actually aren't going to staple or stitch you together. They're going to super glue you back together, so you won't have any, okay? Everything inside gets sutured. This then also, the surface is super glued together and an antibiotic mesh is put there, so it comes out with a really nice clean scar. What I want to draw your attention to here on the slide is where it talks about this synovial fluid, so this blue, not really blue, it's just a clear fluid in your body, that's secreted by the synovial membrane. So here, naturally occurring in the joint. That is your joint lubricant. The way that joint gets lubricated is by motion. So you'll find that physical therapy is going to see you early and often because we need to keep that synovial mechanism lubricating your joint. And that's part of the process of reducing your pain, okay? So as we said, important players there, the cartilage, the bone, that's where the remodeling happens, these new caps that you get put on, okay? And certainly that synovial fluid, which allows for things to move. Now, this is an X-ray that shows you essentially what the joint replacement looks like. Now, to me, the knee replacement is more of a recapping or a resurfacing, and you may hear that term used. Medicare and the insurance companies, however, still recognize it as a total joint replacement. So don't get confused by that. It's the same thing, okay? But really, truly, it is more of a recapping. So I have an old prosthetic here, but still representative of what they look like. This is the new end of the femur, which corresponds with the one on the slide on the right there, okay? And the new component that goes into your tibia. So these pieces are going together like this, okay? The ends of the bones are a non-porous, potentially metallic surface, okay? You're actually made out of space shuttle parts, essentially. You're a machine, okay? So they use a combination of different materials now, depending on what particular model of prosthetic you're going to have. You may have some chromed cobalt, you may have ceramic, you may have titanium. It just depends on which model you get. In between the two metallic surfaces, you always have a poly piece, okay? High density polyethylene in there. This acts as that meniscus that you don't have anymore, okay? You'll notice here, this component, if you can see it, that sticks up, that takes the place of your cruciate ligaments, which would be trimmed off. Those are the only ones you actually lose in your surgery. And because they come up and wind through the joint, when I show you this joint model, you can actually see the crisscross at the back. Those are your cruciate ligaments. They don't have any place to be anymore. So those are trimmed, but they're replaced by a post here on the inside. Now this is a cemented prosthetic. So completely solid from the beginning. It's not going anywhere. We don't see knees dislocating. They are rock solid. The piece I don't have to show you here is this component, which is also the high density poly that goes on the back of your patella. Okay, so that lines this surface, which is roughened, causing those Rice Krispies right now, and allows for that smooth slide and glide, just like your original knee, but without the potential for ever developing arthritis like you have now. So it's a nice replacement. As long as you take good care of it, it'll last you for the rest of your life. So now we're going to talk about the hip. Hip is an entirely different type of joint than the knee. This is a ball and socket. I have a hip piece here, but this is a half a hip. So I'm looking at a right hip, just the wing, the top of my pelvis here. So I'm missing some pieces, but you can kind of get the idea of what I'm talking about, okay? So for this one, if my left hand is my pelvis, this represents the socket or the acetabulum of the hip. This is my femur, the top end of it, coming in and intersecting with that shallow acetabulum, okay? So in early, pristine condition, I'm able to create all kinds of motion at the hip that the knee can only dream of, because the hip is really more of a wing, okay? Sits in that shallow socket, it can move around, rotate, flex and extend, ab and adduct. So it goes all kinds of directions. Again, you're bone on bone, okay? The hip, if you look at this model and you admire what we have up above here, is much more reliant on the soft tissue. So the ligaments, the tendons that support it, as well as the capsule that goes around the joint, okay? The knee also has a capsule. That is one thing they have to go through. That actually encloses the joint and keeps that synovial fluid in place, okay? So they do cut through that, but they suture that back together so that whole mechanism can work just like it always has. And just like the knee, synovial fluid here, synovial membrane that secretes it, and we have to get you moving in order to get that to work, okay? So in this case, it's a little bit more remodeling for the bone, a little bit more loss of bone. Sometimes when I've met with people, they're worried they're going to have an amputation and the leg is then repaired and put back on. Not so, okay? Not for either type of joint. They're going to go in and work within the confines. So now with the hip, they're going to come right along, right where the seam in my pants is, okay? Right in here, outside of the joint, right over, again, those bony pieces that you can feel, your prominences there. Now with the hip, typically this area right here, which is the original head and neck of the femur, becomes a bit deformed, okay? For both joints, you may develop some osteophytes or bone spurs, which they'll be removing when they're in there. But the head of the femur in particular is bad about having erosions and things on it. And so when they do a hip replacement, they'll actually cut down a little ways on the femur to the area of the neck. So with your replacement, you have a brand new head and neck, which is different than what you have with the knee, okay? If you could hold this and feel the difference of these surfaces here, you'd find that this one is porous because the bones of the femur are going to grow into that, okay? It's still cemented in place, but it gets extra stability from the fact the bone is actually growing into that surface afterwards, okay? So again, you have the chromed cobalt, titanium, ceramic type pieces, okay, that come and intersect with another one. What I don't have for this model is that there is actually a liner in here. But again, just like the knee, you don't have metal hitting metal, okay? So a little bit more, like I said, bone loss, but again, a very nice, stable surface that can't develop arthritis in the future, okay? So, how long will you be in the hospital? Typically, people will stay with us for 2 or maybe 3 days. How that's counted is by midnights. So if you come in on a Monday, you might go home Wednesday or certainly by Thursday unless there's something unusual. And Tuesday, therefore, would be Thursday or Friday. Okay? But expect to stay with us at least 2 days. It would be very, very unusual for people to go home on the first day. Now, there are some options. We try very hard here at Jefferson to get everybody ready to go home, okay? And that's why we're here today. We want you to be prepared for the potential that you should be able to go home when you leave us, okay? A few people will go home and have home health if you have a difficult place to get in and out of. So say a couple flights of stairs and we don't want you to go in and out of them a lot, that could be an option. But there are some regulations with home health in that you really have to be homebound. So for them to come to you, that is one of the stipulations, okay? So we're planning for you to be able to go home and come back out to have outpatient rehab. We'll talk about that a little bit more as we go. Another option that exists sometimes is the potential to do what we call our swing unit. It says subacute rehab up there. It's sort of like that, but not exactly. We do have a unit in the hospital, subject to availability, where a person can stay with us a little bit longer. We continue your therapy on an even higher track than we did in the first 3 days of your recovery to prepare you to go home. There are also some regulations related to that, in that you have to be able to tolerate 2 hours to 3 hours of physical therapy and occupational therapy a day, not all at once, but throughout the course of the day. And you have to have a really good plan for going home. So, and we cannot make that decision before your surgery. It has to be made afterwards so that we see that you're able to participate and that the plan is in place and that you actually can do the 3 hours of therapy. But for most people, you'll be back to normal or better than your normal right now in 6 to 12 weeks.